This is one of the spot image of the barium meal follow through. Barium meal, sorry. The stomach, it appears of reduced distensibility, and I will confirm it on further images. And there is a large radiolucent filling defect centered within the body and the antrum of the stomach, and the barium, it is filled within the crater of the filling defect, and it is directed towards the lumen of the stomach. And as this is a single contrast study, I cannot comment on the mucosal pattern. And however, contrast is in passing beyond the stomach into the duodenum. And ma'am, the findings are most likely suggestive of malignant ulcer. And ma'am, Carmen meniscus sign, it is also visible. So ma'am, the findings, they are most likely suggestive of malignant growth or ulcer. And next, visualized spine, it appears unremarkable. And next, ma'am, endoscopy biopsy and CT staging workup.
Excellent, very good. Yeah. Tell me more about Carmen's meniscus sign, because you're right, this is that, but I want you to tell the others why you think that.
Ma'am, it is directed towards the lumen of the stomach, and it is not projected outside the lumen of the stomach. And there is the radiolucent halo which between the malignant ulcer and the rest of the lumen of the stomach. And ma'am, if that would be double contrast study, then ma'am, mucosal fold, they wouldn't have reached that ulcer crater due to mucosal edema.
Excellent. Yeah, that's very good. Yeah, these are, you've described most of the features fluoroscopically of Carmen's meniscus sign. So this is a classic example of that. And as you quite rightly pointed out, the crater doesn't project beyond the gastric wall. You've got this large mucosal sort of raised mound mass-like region, which is kind of straddling the lesser curve with the ulcer at the lesser curve. You've got another little pit here that's filling with barium in between that mass there. Yeah. They also describe that the ulcer crater is often wider than it is deep. Yeah, that's another finding they sometimes describe in the literature. But you're absolutely right. This is a single contrast study, as you can see. So we're not really able to comment here on the gastric rugae. But as you rightly said, the folds would, any radiating folds would stop at the edge of the surrounding tissue and they wouldn't reach the crater. And yeah, absolutely, you would do an endoscopy for this to take biopsies and get histological confirmation and do a staging CT. Good. How else do they stage gastric cancer apart from CT?
Ma'am, staging endoscopic ultrasound through endoscopic ultrasound.
Not for gastric cancer. They tend to do that for esophageal, yeah, and that is for local staging. But for gastric cancer, to complete the staging fully, it's actually done with laparoscopy. Okay, so gastric cancer has to be staged laparoscopically. Trying to get my words out there, because quite often you can have peritoneal disease, okay, from gastric cancer, which is occult on CT. Yeah, we sometimes don't see peritoneal disease on CT, which they can see in laparoscopy, and that would upstage the tumor. Okay, and that obviously will have a bearing on how, you know, whether that precludes the patient from having surgery. Yeah.
Okay, ma'am.
I'm provided with a spot image from a double contrast barium examination, in which I can appreciate that the contrast is seen opacifying the fundal region of the stomach. Body of the stomach is elongated, narrowed, and show reduced sensibility. However, contrast is seen passing through the antrum, which is slightly dilated as compared to the body, and then it is passing through the duodenal cap into the small bowel, first and second part of duodenum. Uh, um, I can appreciate that there is a contrast filled defect noted along the greater curvature in the antral region of the stomach, which is seen projecting beyond the lumen of the stomach, and it is filled up with the uniformly. It is filled up with the contrast medium. However, uh, I cannot appreciate that there is any leakage of the contrast or any
Are you sure that it's contrast? Because the contrast's pretty bright, isn't it? Yeah.
yeah, yes.
And as you've rightly pointed out,
नहीं है वैसे muscular
the lumen is outlined by contrast, isn't it? Yeah. Oh,
Yes, madam.
someone's drawing things on the. Who's drawing? So
Hello.
you can see the arrows in the image, yeah?
Yes, madam.
Talk to me about what are they pointing to? I'm sorry, they shouldn't be there, but anyway.
Yes, they are pointing towards some extrinsic compression along the greater curvature of the stomach, which may be responsible for this narrowing of the lumen of the stomach. As I can see that the greater curvature is concaved upwards. It is concaved upwards. So there might be some extrinsic compression which is causing this effect, causing the luminal narrowing of the stomach.
Okay, so there are three methods, aren't there, by which you can have narrowing of a hollow viscus, correct? Yeah? Tell me what they
are. This could be, first of all, this could be from some extrinsic compression. Good. This could be due to the intramural.
Good.
Something in the lumen. This could be something in the wall of the viscus, hollow viscus, or this may be something causing compression from outside of the viscus.
Okay, good. So which one do you reckon? You've got a choice out of three, from without, from within, or the wall. Which one do you think?
There is some haze in the background, and the rest of the bowel loops are also shifted downwards inferiorly. And the walls also appears quite irregular to me. So combining all these features, I think there is some extrinsic compression.
Okay. I mean, I think as to the position of the bowel, I think that's all right, because this image, I think, has been taken at I think the patient's at a slight angle. They're slightly tilted towards the right. You can see, sorry, the spine here, you can kind of follow it. It's kind of going off slightly down there. There's a little bit of a curve. Okay, so summarize your findings and give me some differentials.
Okay, on the basis of this particular image, my findings, the irregularity of the wall of the stomach and the narrowing of the lumen, my differentials will include it could be some gist, maybe some extrinsic extraluminal mass causing this narrowing of the lumen, gastrointestinal stromal tumor, or some pancreatic, because I can see that there is slight widening of the C loop also, but the lumen is quite above it. Okay, and
okay, and what would you do?
Next, I would like to confirm my findings on CT scan.
Yeah, you could do CT scan. Yeah, definitely.
Mhm. The okay.
About the CT.
Yes. Okay. There is marked wall thickening. There is marked thickening of the circumferential thickening of the wall of the stomach without any compromise of the lumen. So, and quite contrast enhancement is also seen of the wall. And this finding is in favor of lymphoma, gastric lymphoma.
Yeah. Okay. Good. Anything else it might be? Any other differentials?
Mm,
What do they classically describe this appearance as? Do you know what the descriptive term is that they use for this type of appearance of the stomach? Can you remember?
Linitis plastica?
Good, excellent. Yeah, so this is a really nice example of linitis plastica, okay? And this thing here that you were talking about, where the arrows are pointing, this is all thickening of the gastric wall, okay? This is all gastric wall. It is grossly thickened, yeah? And that's why you're getting this sort of scalloped appearance, okay, to the gastric lumen, which is markedly narrow, yeah? You can say rugae in the sort of mucosa, but the lumen is very narrow here, yeah? And as you rightly pointed out, you can see this very diffuse thickening of the whole of the gastric wall, and the mucosa here is really hyper enhancing. Yeah, can you see that? You see how white the mucosa is from the contrast enhancement. Yeah, and
Yes, ma'am.
you can see the lumen here is very narrow. There's an air fluid level, so there's a bit of fluid in this stomach. But so this is linitis plastica. So as well as lymphoma, which is a very good thought, are there any other causes of linitis plastica that you can think of?
Yes, some cancers like breast cancers in women.
Excellent. Yeah,
Mm,
good.
they are the cause of this appearance of the stomach.
Good. Anything else?
Melanoma can also cause.
I don't know actually. I'm not sure about that. Not that I'm aware of, but I'd have to go and look that up myself. But metastases, okay, can sometimes do it as well, like from a GI primary, like something nearby, like the transverse colon. Okay, sometimes you can get a spread of colon cancer if it's close in the transverse mesocolon. It can cross the the transverse colon. It can cross the transverse mesocolon and invade the stomach that way, causing a sort of thickened appearance like this. The other thing is serous gastric adenocarcinoma can look like this, and you rightly pointed out lymphoma, and also certain histologies of breast cancer can cause this appearance as well.
Yeah.
This is a spot image of barium meal. I can see contrast opacifying the stomach and extending into the duodenum and some jejunal loops. So there is a filling defect at the fundus of the stomach with contrast going into the interstices, and it is away from the bowel wall, and the contrast is seen to be extending normally into the rest of the stomach and into the duodenum. So my findings would be in keeping with the gastric bezoar formation.
Good, very good. So this patient, okay, has had gastric surgery. You can see here that you're not getting the normal continuity of the duodenum, okay?
Yeah.
This is the duodenum, the oversewn end of the duodenum here, yeah? And they've this is continuing. So you've got the jejunum here, and they've pulled up a loop of jejunum and performed a gastro-jejunostomy. Do you know what kind of surgery this is?
This could be a Billroth's 2 kind of procedure.
Yeah, absolutely, that's right. So it's a Billroth 2. And Billroth 1 gastrectomy, the anatomy looks very, very similar to a normal anatomy. So sometimes you can't really tell unless they tell you in the clinical history. But in this case, we can see that the duodenum is discontinuous, and you've got the sort of downstream jejunal loop that's been anastomosed. And as you very correctly pointed out, you mentioned this sort of filling defect, which is mottled, it's large, it's in the gastric fundus, and a known complication of gastric surgery, gastrectomy, can be Bézoar's formation, which can be of various types. I mean, you can have plant material. I mean, some people, you know, especially people who have psychiatric illness, they can ingest hair. You can sometimes see trichobezoars from hair, even from congealed medication, which they call pharmacobezoar. So it's all very strange. Yeah, that was very good.
This is a one spot film from the barium meal examination, single contrast. There is contrast specification of the stomach and the duodenum first duodenal cap and duodenum first and second part is specified. However, there is abrupt narrowing is seen at the first and possibly third part with the mild contrast is passing into the small bowels loops.
If I told you they had gastric surgery, would that help at all?
Okay.
So thinking about the last case.
Yes, madam.
To reconsider this case.
Yes. Okay. I think it's stomach is anastomosed to it's duodenum, so it's possibly it's a gastroduodenoscopy, Billroth 1.
I don't think it is a Billroth. Actually, I think it is anastomosed to the jejunum. It's just that on this image, it's a bit angulated.
Okay.
So seeing, if I tell you that the anastomosis is probably here, I think that's probably the anastomosis there.
Yes, it's a gastric. It's a gastrojejunostomy, and the this other part distended is the duodenal or distended, and there must be some growth at the or stricture at the duodenum second part or third part.
Good. Yep. Good. So do you want to summarize your findings and tell me what you would do next?
Okay. This is a gastrojejunostomy with the suspicion of mass at the duodenum. So I would further need a CT scan with contrast to further characterize or further describe my findings.
Good. Yep. So this is what we call afferent loop syndrome. Okay.
Okay.
So what I'll do is I'm just gonna quickly show you this diagram. Okay.
Yes, madam.
Just to recap the difference between Billroth 1 and 2.
Okay.
I agree that on the image I showed you, it wasn't as clear as on the image before, which showed your colleague.
Yes.
But that was partly because this loop was so dilated. Okay, so when we talk about Billroth gastrectomies, we have, so what they do is they've obviously removed this portion of the stomach, so usually a bit of body, the antrum and pylorus, yeah?
Yes, madam. Yes.
And then you're then left with a free end of duodenum, yeah?
Yes.
And the rest of jejunum downstream. So
So
then what they've done is they oversow this blind end of duodenum. This remains in continuity with the biliary tree, yeah, the ampulla, and then the downstream bit of jejunum they then connect to the stomach, so the gastrojejunectomy. Okay.
Yeah. Yes.
So this loop of bowel they call the afferent limb because it's approaching the stomach.
Yes.
Or the more correct name is the biliopancreatic limb. Okay. Because it's connecting to the biliary tree and pancreas. So this is the biliopancreatic or the afferent limb. Okay. And once the loop reaches the stomach, the loop that goes away from it, so you can see with this arrow here, this is known as the efferent limb or the limb that's leaving, or the correct name is the alimentary limb. Okay. Alimentary as in gut. Yeah. That makes sense.
Yes.
So, as you rightly pointed out, what happened in that case is there was a stricture here, okay, of the afferent limb, which meant that all this section was dilated, okay?
Yes, madam. Yes.
So, can you give me some causes of obstruction potentially?
But duodenal atresia, web, and annular pancreas. In
those are more common sort of in like younger people. Yeah?
Yes, madam.
The gastrectomy. I mean, you mentioned the mass, which is
madam. Adenocarcinoma, lymphoma.
Yeah.
And GIST, metastasis.
Yeah, possibly. And what else causes bowel obstruction, like commonly?
Adhesions.
Good. Adhesions. Absolutely.
Yes.
So in this particular patient, okay, the actual cause was an adhesion. Yeah.
Okay.
But, you know, given that a lot of these patients have surgery for for gastric cancer.
Yes.
Recurrent gastric cancer is definitely something you need to exclude, and you are absolutely right to suggest the CT scan. Okay.
Yes.
Okay.
Ma'am, I'm provided with the abdominal radiograph with the I'm not sure about the contrast study, but I can see that the stomach is distended with the linear radiolucency is noted within the wall of the stomach. It is tracing along the lesser as well as greater curvature.
Good.
If this is a plain study, then this lucency is abnormal. This is air within the wall of the stomach, and the stomach lumen also appears to be heterogeneous. It is dilated with air fluid level within it, and multiple foci of air are also noted along the in the medial aspect of the stomach along the lesser curvature. So my diagnosis is emphysematous gastritis.
Good. Yeah. What else might you do to confirm it?
Ma'am, I would like to do CT.
Yeah. Okay.
In the provided image of the CT scan of the abdomen taken at the level of the stomach, and the oral contrast has been given to the patient, and there is air within the wall of the stomach,
along with abnormal air is noted in the bed of the stomach as well.
Mm-hmm. Yeah.
So stating retropneumoperitoneum.
Good. Excellent.
So, ma'am, I cannot, ma'am, point to the cause of this retropneumoperitoneum in this patient.
Mm-hmm. Can you give the causes anyway? What might give you emphysematous gastritis?
Ma'am, the history of diabetes in this patient?
Yeah. I don't know if this patient had diabetes, but yeah, definitely. Because what does diabetes predispose them to?
They are more prone to the infections by the gas producing organisms.
Good. Yeah. Anything else?
Ma'am, ischemia.
Excellent. Good.
We can also ask any history of atherosclerotic disease in the patient to rule out ischemia.
Mm-hmm. Yeah. Anything else?
Ma'am, currently, ma'am, just I can remember these two causes.
That's fine. That's very good. Gastric obstruction can sometimes cause it as well.
Okay.
If it's very severe.
Okay.
For instance, in the case of gastric volvulus, that might be one cause. And also lye ingestion as well, because that can disrupt the mucosa, and cause gas to get in that way as well.
Okay, ma'am.
You can have benign causes of gas in the bowel wall, but those tend to be more common in the small bowel and the colon, not really the stomach.
Yeah, ma'am.
Okay, that was really good.
Thank you, ma'am. Thank you.
Barium swallow. Hear me now?
Hello.
Can you hear me?
Yes.
Hello?
Yeah.
Okay, I'm provided with spot film of barium swallow in male, and in the given images, I'm able to appreciate that there appears to be abnormal rotation of the stomach with greater curvature pointing upwards and lesser curvature downward. The pyloric and gastroesophageal junction appears to be normally located, and the stomach is intrathoracic in location. There is passage of no gastric outlet obstruction is noted in this case. Based on these findings, my provisional diagnosis is this is likely gastric volvulus, and most likely it is organoaxial. So I would like to confirm my findings by passing an NG. If patient we are unable to pass NG, that also confirm to my diagnosis, and further I will refer the patient to the if he's symptomatic, like retching or vomiting or like toxic, so it will be immediate surgical referral is suggested.
Excellent, very good, absolutely. So this is gastric volvulus, and you rightly pointed out, this is organoaxial volvulus. Can you tell your colleagues why you think this is organoaxial volvulus and what the other type of volvulus is?
Yes, ma'am. Usually in organoaxial volvulus, when the greater curvature of the stomach, which usually lies downward, it is upward in organoaxial, and lesser curvature is downward. So that points to the diagnosis of organoaxial, and it is likely a long axis flipping of the stomach, and in short axis flipping like in mesenteroaxial, usually there is rotation of the places of the gastroesophageal junction and the pylorus.
Excellent, very good. Yeah, absolutely. So here you have what they call the classic mirror image stomach. Yeah, as you rightly pointed out, the stomach's twisting along its long axis, so the lesser and greater curves are reversed. In mesenteroaxial volvulus, the stomach's rotating along its short axis, so it's almost like it's kind of folding, and the pylorus will be above the GOJ usually. Good. Do you know what can predispose people to volvulus?
Ma'am, usually some hiatus hernia may predispose to the abnormal malrotation.
Excellent. Yeah, hiatus hernia. That's right.